for your interest in American Journal of Orthodontics and Dentofacial Orthopedics. I am Letizia Perillo, Professor and Chairman of the Postgraduate Program in Orthodontics at the University of Campania Luigi Vanvitelli in Naples. It's a great pleasure to share with you my experience on cleft patients. So let me first introduce my co-workers, Maddalena Vitale and Fabrizio D'Apuzzo from my department, Gaetano Isola, Riccardo Nucera and Giovanni Matarese from the University of Messina. As you know, the treatment of cleft patients requires a great interdisciplinary approach. And believe me, with Antonella we really did our best. So we truly hope you enjoyed this case. Thank you.
The patient was a Sri Lankan girl, aged 12 years and 6 months, in late mixed dentition with a UCLP on the right side, and who was surgically treated at 6 months for her lip, at 12 months for the soft palate, and at 18 months for the hard palate, in accordance with our protocol. She had an irregular smile and a slightly asymmetric face, and so she was unhappy. Moreover, her profile was convex, with a protruded upper lip, a reduced nasolabial angle, and a protruded lower lip. The occlusion showed a class 2 molar tendency with a full class 2 canine relationship on the right side, and a full class 2 molar with a canine class 1 relationship on the left side. The maxillary arch had a bilateral crossbite with a lower midline deviation. Overbite and overjet were decreased. The maxillary incisors were rotated toward the cleft side, the maxillary right canine was buccally ectopic, and both deciduous canines were still present. The patient had a severe crowding of about 10 mm in the maxillary arch, and a mild crowding of 4 mm in the lower one. The panoramic X-ray showed included, transposed, and anomalous lateral incisors, an impacted maxillary left canine, and a severely mesio-inclined mandibular left second molar. The lateral cephalometric evaluation showed a skeletal class 1 malocclusion with a vertical growth pattern, retroclined maxillary incisors, and proclined mandibular incisors. So the problem list of the patient was long and complex, including expansion of the upper maxilla, correction of the midline deviation, control of the vertical growth, correction of upper and lower crowding, correction of the molar, canine and incisor relationships, extraction of the included, transposed, and anomalous maxillary lateral incisors, repositioning of the impacted maxillary left canine, uprighting of the mandibular left second molar, and, as far as possible, aesthetic improvement. Before starting treatment, we considered different options, ranging from no treatment at all to treatment with 4 extractions or surgery in adult age. At the end, the treatment with extractions of the maxillary lateral incisors and mandibular first premolars was selected, although the treatment started with a bonded maxillary expander to gain some space in the upper arch. So, after a few months, the maxillary deciduous canines were extracted, and 0.018 by 0.025 inch Alexander fixed appliances were applied. Alignment of the maxillary central incisors was started with a 0.014 inch nickel titanium arch wire, whereas the maxillary left canine was erupting palatally. In the mandibular arch, instead, first a lingual arch and second premolar brackets were applied to achieve derotation. Then the maxillary right canine was repositioned with a 0.016 inch nickel titanium arch wire, while a 0.016 inch stainless steel sectional wire was used to maintain the alignment of the central incisors. In the mandibular arch, a sectional wire with an open coil spring was applied to upright the left second molar that was severely mesio-inclined, impacted under the first molar and constricted by the third molar. Uprighting was achieved after 6 months, as shown by the panoramic X-rays. After 1 year, the maxillary expander was removed, and both arches were fully bonded. In both arches, levelling was performed with a 0.017 by 0.025 inch nickel titanium arch wires. The maxillary left canine was moved to the lateral incisor position. The mandibular first premolars were extracted, and the canines began to retract. Subsequently, both the left and right maxillary lateral incisors were extracted by an oral and maxillofacial surgeon. and a transpalatal arch was used to derotate the maxillary molars and improve the arch form. In the mandibular arch, the canine retraction continued. 2.5 years later, space closure in both arches was achieved, and 0.017 by 0.025 inch stainless steel arch wires were used to coordinate the arches for finishing. After debonding, a maxillary lingual arch and a mandibular canine to canine bonded retainer were applied. Restoration of the maxillary canines and premolars was requested for aesthetic and functional reasons, but the patient preferred to postpone these treatment procedures until her adulthood. The overall treatment objectives were achieved. The patient had an improved smile and profile. The occlusion showed a well-aligned dentition with a class 1 molar relationship, a consonant smile arch, and good tooth interdigitation. The crossbite and the midline deviation were corrected, and normal overjet and overbite were achieved. The initial crowding was completely resolved in both arches, and the post-treatment panoramic X-ray showed good root inclination. Superimpositions showed good sagittal and vertical control, and correction of maxillary and mandibular incisor inclination. The treatment lasted 3 years. The patient was greatly cooperative and pleased with the outcome. After a 24-month retention, the occlusion was stable, and, as usual in these patients, a fixed lingual arch was applied in the upper arch to prevent any tendency to relapse.